Does that come up okay?
That looks all good, thank you.
Okay, so thank you very much for inviting me. I do feel a bit in awe following Emma after amazing sort of presentation about the fantastic work that she's doing. So just a little bit of introduction to myself and to Rethink Mental Illness. So for those of you that haven't heard of Rethink, we're a national charity that works to improve the lives of people severely affected by mental illness. Some of that is through commissioned services, so have a presence in local areas where we're commissioned to run supported accommodation, crisis services, other sort of mental health services like that. We also have a national presence through policy, campaigning and advocacy work. And we also do quite a lot of work around sort of co-production, proof of concept. So looking at how we can work with people with lived experience in terms of improving the system. And that's sort of where the work I'm doing fits in as well. So I'm the place-based physical activity manager, leading on a Sport England funded piece of work to improve physical activity access for people severely affected by mental illness. I'll explain a little bit about what we mean by severely affected by mental illness and severe mental illness. So severe mental illness normally refers to sort of psychosis-related conditions. So that'd be conditions such as schizophrenia, bipolar disorder being the most common of those conditions. If we talk in terms of prevalence, so for schizophrenia, it affects about 1 in every 100 people. Around about 1 in every 50 people in the UK live with bipolar. So if we think about overall mental health, mental illness, you look at about 1 in 4 people that will be affected by depression, anxiety disorders at some point. So a much lower prevalence for severe mental illness. But we know that the inequalities and the impact around that is even more severe. We also deliberately use the term severely affected by mental illness a lot of the time. And with that definition, it includes people with severe depression, anxiety disorders, usually to the extent where they've had contact with secondary care, mental health services as well, rather than people living with mild to moderate depression where it might be managed within primary care. Having said that, we've been very deliberate within our work that we wouldn't exclude people. We know there's a lot of people who might have quite poor mental health that haven't had a diagnosis, people with mental health conditions that are being managed within primary care that would really benefit from some of the work that we're doing. But what we wanted to do is to make sure that the voice of the people with those more severe mental illness isn't being drowned out by a sort of a wider group of people with sort of wider mental health conditions as well. So we've got really focusing on that severe mental illness part of the work there as well. Talk a little bit about some of the health inequalities, particularly around physical activity and physical health. So we know that the life expectancy of someone living with severe mental illness is around 15 to 20 years less than the overall population. And if you compare that to some of the health inequalities around deprivation, so if you think about your local areas, then between the most deprived area and the least deprived area in a region, you're probably looking at something like 7 or 8 years difference in health, in life expectancy. Whereas for people living with severe mental illness, it's 15 to 20 years. So a massive impact on life expectancy through severe mental illness. We know that a lot of that is down to poorer physical health as well. So people are more likely to have respiratory conditions, more likely to have cancer and sort of later stage diagnosis of cancers. A lot of that life difference is also due to cardiometabolic disease, so diabetes, types of diabetes, particularly cardiovascular disease. And we know that people living with severe mental illness about 2 to 3 times increased likelihood of developing a cardiovascular disease as well. We talk about actual physical activity uptake. So we know that cardiovascular disease and a lot of other physical health conditions can be managed or prevented through physical activity. yet there's significantly lower levels of physical activity and higher sedentary behaviour in people diagnosed with severe mental illness. The Sport England funded work that we're doing, it's place-based and specifically working in Tower Hamlets and North East Lincolnshire. As part of that work, we did some surveys to get an idea of how active people were, to also understand some of the barriers to physical activity. And from that work, we found that people living with severe mental illness, generally less than 10% of people were meeting the Chief Medical Officer guidelines of at least 150 minutes of moderate activity a week. And almost 2/3 of those people were achieving less than 30 minutes a week. So really, really low uptake in physical activity on that as well. So a real sort of issue, something that you're sort of addressing through this work that we're doing on that as well. Talk a little bit about some of the system level barriers. So what I want to do today is just explain a little bit about sort of the work we've done so far, what we've identified as those barriers, and what sort of solutions we're putting into place, what sort of things you might be able to sort of consider within your own work and the sort of the area that you're working in as well. So we basically designed a survey questionnaire, worked with people with lived experience to sort of understand what the barriers were to them. We did a literature review to incorporate any previous learning that had been done around that. And the survey questions were co-designed with 8 experts by experience, 8 people with lived experience of severe mental illness, in terms of the wording of the questions and how it made them feel answering the survey as well. We had around about 3 to 4 questions for each of the domains that we'd identified as being likely barriers to people being more physically active. And we used a 5-point Likert scale on a scale of strongly agree to strongly disagree with that. We used the surveys in the place areas to understand what the local barriers were and to be able to prioritise interventions in the work that we did with local stakeholders within that work. We've recently widened the survey to collect responses England-wide. It's something that we're doing in the run-up to Mental Health Awareness Week. I can share the link to that later, and if anyone is able to share that through your local networks as well, it'd be really interesting to find some of the responses in other areas and to get that sort of England-wide picture as well for the barriers for severe mental illness are there. Some of the domains that sort of came through, social influence came up as being one of the biggest sort of barriers or enablers that people would be much more likely to be physically active if they had the support of others. There was a lot of discussion around healthcare professionals that they should be talking about physical activity and that people would be more likely to be active if healthcare professionals had those conversations. Having someone to be active with as well would really encourage people. The mean score at the bottom of the slide there. So basically using the survey questionnaire and the scale that we used, if someone strongly agreed with the top statements, that'd be more likely to be physical active if I had the support of others. If someone rated that strongly agree, that would score 5. If someone strongly disagreed, it would be a score of 1. So the higher the mean score, the more of a barrier it is, and the mean score at the bottom is for all of those questions. We sort of group them together within social influence. So that was actually the highest scoring, and the questions about healthcare professionals and having the support of others scored the highest. So we knew that we really had to do something to work on that sort of social support, social influence for people within the work that we were doing. There was a lot that came up about considering the choice of exercise that people had. And certainly one of the key things that I was keen to do within this project is not to say that, because you've got a severe mental illness, there's a badminton group you can go to on a Monday morning, or we've got a walking group on a Tuesday, that people should have that support to access whatever activities they want to do. So part of it was being able to sort of support people to make their own choices and to access different activities. But a lot of the feedback we were getting was also, particularly people living with schizophrenia, were saying, I feel safer exercising with people that have the same condition because they understand me. So on one hand, it's making sure that we provide environments that people feel safe, but also doing what we can do to reduce stigma around severe mental illness and making people feel more included, more involved in other activities and sports as well. So that's a big part of the work that we're doing. Done a lot of work in terms of looking at the needs of carers and family members with caring responsibilities, that they felt that there was benefits of physical activity, but often found that they didn't know how to support the person they were caring for to be more physically active. So we're doing some work in Tower Hamlets with the Carers Centre there, to really delivering some health influencing training, to upskill carers and family members to be able to talk about health and how to improve your health, and to be able to do some physical activity with people, based on some of the We Are Undefeatable resources around movement. But we found that a lot of people with severe mental illness didn't engage as much with some of the online activities and things as well. So it's looking at how we can support people locally to have access to those sort of things. And also, we know that the quality and the quantity of conversations by healthcare professionals on physical activity has been quite mixed. There's a lot of work going on with things like the physical activity clinical champions work in the areas where that applies. It's a fantastic initiative. Some of the work we're doing is looking a lot more at linking in with things like physical health checks. So people with a severe mental illness are eligible for an annual physical health check because of the amount of the inequalities on physical health. And so trying to encourage conversations about physical activity within those, but also where we're trying to increase physical activity conversations, make sure that those ad hoc conversations encourage people to take part in the health checks as well. So got quite a lot of work going on at the moment as well to address that. One of the other domains that scored very highly was around capabilities, or belief about capabilities. And a lot of that was down to mental health conditions, making it hard to be active, and medication, making it hard to be active. So that was quite a high score, something that we're considering within the work that we're doing. There's a really, really significant effect on people's physical health. Some of the side effects, particularly from antipsychotics. So the quote there is from one person who's had a diagnosis of bipolar, put on antipsychotic medication. And this is someone that was really active prior to diagnosis and treatment, that she used to go to CrossFit. So anyone that's done CrossFit will know sort of how intensity that sort of activity is. Since then, put on 3 kilograms in weight, and that was over a period of sort of about a month or so. Finds it much more difficult to achieve what she used to do previously. Doesn't think she'd be able to do 10 minutes of intense activity now. So it has a really significant effect on weight, lethargy, can cause excessive sweating, which you can make people feel quite uncomfortable, quite sort of conscious. Also increased heart rate. And I think if people also have like anxiety and they feel that the heart rate's really increasing a lot with exercise or because of the medication, then that can make it worse as well on there. And again, really important with things like considering time of day and stigma about severe mental illness within that as well. We looked a lot at sort of what we class as environmental context and resources. So that's really what's available to people in their local area. If cost stops people from doing activities. There was a lot, particularly in Tower Hamlets, around a lack of culturally specific activities, and where people feel safe going to activities, things like that. One that scored the highest for that is that people said that they'd be much more likely to go to a gym or activity if instructors had a better knowledge of mental health condition. So we know there's some fantastic work that's been done around sort of wider mental health and well-being. But it really sort of highlighted in the survey that a lot of people still felt that people within gyms and physical activity provision didn't really understand severe mental illness the same. So some of the work we're doing, we're actually working with the leisure services, both in Tower Hamlets and in North East Lincolnshire, in terms of how we can improve provision. In North East Lincolnshire, they've already got mental health first aiders within the staff, which is fantastic that they're doing that. It's something though it wasn't promoted. So people had fed back to us that if there is mental health first aiders available, can they have a board up saying who the duty mental health first aiders are? Can they be introduced to people when they come along? That type of thing would be really, really important. Also, from the perspective of the mental health first aiders, what we found is that they did the mental health first aid training, but there wasn't any one that they could sort of talk to afterwards. If they'd had a conversation with someone and found it quite distressing, there was no sort of clinical supervision or anything like that. So it was looking at how we can work with Navigo, the local mental health provider trust there, to improve access for having those conversations and getting that support for the mental health first aiders as well, and then making sure that they're able to signpost to services as part of that work as well. We've looked a lot within this work about having wellness action plans written up for people that are attending, also potentially using crisis cards, where there's like a little card that's got phone numbers and things, and putting those in areas where they're fairly quiet. So you're putting them in sort of toilet areas and places where people might go to be on their own, where it's quiet, rather than thinking that someone's just going to go up in a busy part of a leisure centre and pick a card up in front of a load of other people. So looking at working on things like that within the project as well. We did a listening event with a number of experts by experience and local stakeholders, where they talked about what some of the barriers might be to go into a leisure centre in the first place. And a lot of that was that uncertainty about what to expect, who they're going to meet, who they can speak to if they have any concerns, that type of thing. So I've done a lot of work in making sure that that's communicated before people go along to the first session. The other thing that came up a lot was around better awareness of training on severe mental illness, thinking particularly within exercise referral schemes. So that was one of the areas that generally the training for exercise referral covers mild to moderate depression and general anxiety disorders. It doesn't include severe mental illness. There was some really, really sort of poor examples, not from the two areas that we're doing this work in, I have to sort of stress, but from some of the wider work that we were doing. We asked around people accessing leisure centres, and with a severe mental illness. One of the responses was that someone with severe mental illness can come in and exercise if they've got a carer with them, which is sort of totally inappropriate. That most of the time people will not need or want a carer to be with them. If they do, that's down to that individual's sort of choice rather than the leisure centre saying that. But then on the other end scale, there was someone saying that we've got someone that comes in, sometimes falls asleep on a machine, but it's okay because it's just his medication. So some real sort of bad practice, some examples that have been highlighted around that. And so a lot of the work we're doing is creating some training for within the fitness industry around some of the screening, so particularly around sort of cardiometabolic risk, making sure that people are safe exercising, but also really reducing that stigma and having that understanding of how to support people better within that as well. So that's a lot around that side of it. Emotion was one which didn't score as high as we thought it would do. So that's looking at where people are put off doing activity because of anxiety or starting to worry when they think about physical activity. So that got a mean score overall of 3.15. So slightly more people felt that it was a barrier, agreed or strongly disagreed, than were neutral or didn't feel it was a barrier. But still there was a lot of individual discussions around where people do need that more in-depth emotional support for going along to sessions. So people often talked about a negative experience of attending somewhere, but it didn't necessarily mean that they'd avoid that place. So it didn't necessarily mean they'd avoid activity, it just meant that they might not go back to that same location, which obviously we still want to address that and make sure that people have a positive experience wherever they choose to go. But it's more a case of supporting people as well. Some of the examples that came up for that as well, there was one person with lived experience of schizophrenia who also has a physical disability, which meant that he wasn't able to use the stairs. So he was put into a goods lift to access the gym, and it was basically a metal cage. And he was someone who had been sectioned previously. So you think about the trauma of being sort of bundled into a metal cage to get up to use the gym is a really sort of significant impact on there. And I think it was just a real sort of lack of thought within that place. Looking at ways of reducing negative emotions, so building in mindfulness, graded exposure to the physical activity sessions, so they can meet someone maybe in a different location first, and then come along and just have a coffee at the location where they're exercising, or coming in, it might be more of sort of a mindfulness session or an information session, things like that, and then just gradually building up that exposure to physical activity. Whilst doing a lot of work with social prescribing services, so some of the emotional barriers might be around things like, I don't really feel I have the time, I'm too stressed to think about physical activity because I've got all these issues around debts and having to look for work and things like that. And so we're always making sure that we're linked in with the social prescribing services where they might want to look more at wider determinants. One of the issues which has come up quite a lot around severe mental illness is the number of people that fall between a gap. So in one area, it was found that people with severe mental illness were quite often excluded from the social prescribing service because it was felt that the social prescribing link workers weren't qualified to work with people with those conditions. And yet those same people were sometimes excluded from having a care coordinator or support within the mental health trust because they were considered too well. So it's like they're not ill enough to have the support from mental health services, but they're too ill to have the support from the social prescribing in the community. So there's a few things there that we're working on, which had sort of flagged up as being some really significant issues there as well. One which was quite a surprise within the survey response, and also some of the wider work that we've done in sort of focus groups, was looking about the belief about consequences. So what would I get any benefit from being physically active? Is a sort of key question. And that scored very lowly, 1.42. So that meant that the majority of people felt that they would get lots of benefits from being more physically active. So it's much more around barriers that are stopping them being active rather than a lack of motivation or a lack of will to want to be physically active. So it's quite interesting, the scoring on that. So we've obviously dug a lot deeper into looking at what specifically we need to focus on in terms of encouraging people to be more active within that as well. Some of the key things around that is particularly around physical health. It often wasn't seen as a reason for being more physically active. So the thought of you doing physical activity and it will reduce your risk of developing heart disease, or it'll help manage your type 2 diabetes, that type of thing. That wasn't really considered something important to people. They were much more interested in the mental health barriers, and particularly the short-term mental health barriers. So a lot of it was more about functioning better, feeling better, that type of thing. Also quite a lot about social benefits from doing physical activity. So you're wanting to be active with other people and get those social benefits, but often needed a lot more support to feel confident going and doing some activity in a group as well. I think that's a really interesting one when we look at the NICE guidance on physical activity. So particularly for schizophrenia, the NICE guidance is to focus on conversations about physical activity, but mainly around improving physical health. So if we're just talking to people about being active to improve the physical health, that might not be something that's a great motivator. So we might have a different message for people in terms of the benefits of exercise around short-term mental health benefits. rather than the sort of the nice guidance message around that physical activity should be recommended to help improve physical health in people living with schizophrenia. So that was quite an interesting thing that came out from that as well. Some of the research around physical activity and severe mental illness. So there's been a number of studies, systematic review, sort of flagging there. Quite interesting in terms of sort of the amount of exercise and intensity. It showed that psychiatric symptoms were significantly reduced using around 90 minutes of moderate to vigorous exercise per week. And that also significantly improved functioning, comorbid disorders, so a lot of the physical health conditions, and sort of cognitive ability as well, which we've seen as a sort of really, really key within the work that we're doing. So we know ideally looking around about sort of 90 minutes. Vigorous exercise, it may depend a little bit on sort of cardiometabolic risk factor with sort of different comorbidities that are going to have an impact on safety to exercise at a vigorous level, but it potentially could be a little bit less than the chief medical officer guidance as to how much we need to be doing each week, but still significantly more than a lot of people were managing to do without any sort of intervention for people that are living with severe mental illness. So that's a little bit on there. Just going to talk through a little bit now around the sort of the system level approach that we're using within the two areas. So from the work that we did initially, it sort of split into three sort of parts of the system. So we were looking at how or who is having initial conversations about physical activity. What should that sound like? Who should be having those conversations? What training is required for people to be able to do that? Once people have had those initial conversations, what in-depth support is available for people? So it might be that in some cases, someone can have a conversation and say, yeah, I'll go along to the leisure centre, and they'd go straight to that physical activity. A lot of time, people would need a much more in-depth conversation and support to address some of those barriers. But then once that's happened, we want to make sure that people have a really positive experience when they actually go along and access physical activity. So in terms of the initial conversations, I've done quite a lot of co-production work to understand who's best placed to have the conversations. We're currently working on a Making Every Contact Counts type resource that's been piloted with some of the primary care networks and mental health trusts. And that is specifically around some of the barriers for severe mental illness, and also linking into the physical health checks with that as well. Some of you might be familiar with the NHS Core 20+5. So that's really sort of highlights the key inequalities and the key areas that the NHS wants to focus on in terms of sort of health inequalities. And of that +5 part of Core 20+5, one of those 5 conditions is severe mental illness, and specifically working on improving uptake of physical health checks and also the quality of physical health checks within that. So we're doing quite a lot of work on that. And I think there should be good opportunities locally to be able to link in with that type of work and to be able to be part of that physical activity solution for some of that work as well. So our work's ongoing in terms of demonstrating good practice and some of the resources on that as well. A lot of the work about the in-depth conversations, what we're making sure that we do is looking at what roles already exist in place, but then really highlighting where there's gaps, where there's people that fall between those gaps. So we're sort of piloting some physical activity champion and navigator roles in those 2 areas, but linking in very much with the existing navigators. So they're supporting social prescribing link workers to have a better understanding of physical activity. They're picking up work with people that fall between the gaps and between some of the other services within that as well. So it's sort of quite a fluid sort of piloting that we're doing at the moment to bring that into place as well. And then the final part around access to physical activity is very much about working with the local leisure services. At the moment, we made the decision to focus on a small number of providers, so mainly working within the local leisure services, to be able, local leisure provider, to be able to look at what good practice should look like, And then from that, we're creating a guide to support other physical activity providers around good practice for severe mental illness. And then we're going to pilot that with some of the other providers in those areas. And then towards the end of the project, there'll be a sort of a national shareable guide to good practice for that as well on that. So that's just sort of a very brief overview of the system level work and how we're sort of working with experts by experience to work on that. Probably worth just mentioning as well that our approach to co-production is very much at that sort of system level. So we're working with the Integrated Care Board, working with the mental health trusts, and the way we sort of define co-production is where you've got experts by experience working in equal partnership with experts by training. So it's having meetings where we've got experts by experience that feel confident speaking and are supported to sort of get their views across, and they're having an equal say alongside representatives from the leisure services, from the mental health trust and other organisations. So it's a real sort of co-production practice that we use for all of that work in those areas. A little bit in terms of some of the future outputs from the work as well. So mentioned about some of the findings that we'd had from the survey questionnaires. We've now sort of gone out nationally to get as many responses as we can from sort of wider areas, and then with that it will enable us to sort of break down some of the data into different mental health conditions. So because of the number of responses we got in the 2 place-based areas, we couldn't necessarily have confidence in the statistics if we broke it down into a certain age group or people living with a particular mental health condition. So with a much wider number of responses, we can look at some of the data for those type of things as well. That should be shareable by around May, June time of this year. Creating an e-learning product for fitness instructors, mainly aimed at people working within exercise referral schemes, to sort of upskill to be able to then work more effectively and safely with people with severe mental illness. But it will be available for other people that are interested in sort of going through that as well. That's around about May, June time as well, that should be finished. The good practice guide for physical activity providers, that's been written up, and then that will start to be piloted over the next few months, and then it'll be about August, September time that will be available for sharing. Working with the Centre for Mental Health as an external evaluation partner, and they will be producing a national webinar, which will be towards the end of the project, around January 25, or after the end of the intervention work of the project. And so we will make sure that we circulate links for that as well. I'll give a more sort of in-depth review of the findings and how that can be replicated in other areas as well. And then that will be supported by a final report by the Centre for Mental Health, which will be released at the same time for that as well. And I don't know if I think I have actually maybe sort of went a little bit too quick going through those first few bits. I think I'm actually ahead of time now. So hopefully we've got time for some questions and things as well.
Yeah, no worries. Plenty of time for some questions. So we've had a few come in. One that's come in just now straight away is, this all sounds brilliant. I think it's particularly talking about future plans. How can people ensure that they receive resources and stay connected to your work?
Right, yes. So I can share my email. I can pop that in the chat and then people can sort of get in touch around that, and we can make sure that you're included on those lists. Certainly, as part of the sort of wider dissemination, we will be going through sort of active partnerships, going through Sport England, working with Mind, to sort of get some of those out when we get to that point as well. So hopefully people will receive that through the sort of the usual channels that they're sort of linked into. But I can share my email address at the end as well, if anyone wants to get in touch about anything as well.
Yeah, we produce a mental health newsletter for the region. So if that's circulated to active partnerships, if everyone who's attending here signs up to our newsletter, we can make sure that that's included in future newsletters to help share that information. There's another question as well around the referral, if there's a referral procedure to Rethink Mental Illness.
Right, so for the physical activity work, I'm guessing that's the question. So I think obviously Rethink do run a number of different services in different sort of areas. So some of those services might be referral based. But in terms of physical activity work, we wanted to make sure that it was accessible to as many people as possible. So some of the sessions that we're supporting the leisure services to set up, you don't need a referral. People can just turn up and access those sessions within that. We are working often within exercise referral schemes. There is the referral for that part of it. And again, that is an area that a lot of people with severe mental illness fall between a gap, that if they don't have one of the conditions that's covered within exercise referral, then they're often excluded from that. So if someone has schizophrenia, but doesn't have type 2 diabetes or doesn't have depression, anxiety disorder, they may not be eligible for the schemes. So we're wanting to make sure that we can include people without a referral for all of the work that we're doing.
Perfect. There was actually other elements to that question. Sorry. So it was coming from a social prescriber, and they were talking about potential wait times around this. This might be Rethink's work more generally, but I don't know if there's anything you can add to that in terms of wait times for that exercise referral.
Right, no, so certainly, just I think I know that it may be that it's sort of different works. I know that we are doing some work in Bedford around like a navigator role, which is sort of a different sort of element of Rethink. I'm not completely sure if they have got a waiting list at the moment for that, but certainly within the work that we're doing in North East Links and Tower Hamlets, people can be supported to access sessions straight away, that there's no waiting list for that at all.
This person who's put this question has put about potentially reaching out, and I think if you were including your email address, it might not necessarily be yourself, but it might be someone you could potentially connect with locally.
Absolutely, yeah. We've actually, one of the pieces of work that we've done at Rethink as well, alongside this, is to set up more of a sort of a community of practice within the charity for anyone that's doing bits of work around physical activity and physical health. So we do have like sort of bi-monthly meetings now where it brings together people that are doing things in other parts of the country. So we're starting to get a much better, or make sure we've got a better understanding of what's going on, and having those links to that.
I'll encourage them to get in contact with you, or
Right, yeah,
after, and then take that. So there's one more question. So do you think mental illness is worse now, or do you think mental illness is being more understood in the mainstream and taken more seriously?
That is a great question. I think there certainly seems to be a lot of stigma around severe mental illness, and you sort of think about how severe mental illness is portrayed on the news. Certainly looking at how people that we're working with a diagnosis of severe mental illness, how they often feel, then I think it seems that there's not been that much progress made. I think there's a lot to sort of highlight what needs to be done. But I think a lot of people do feel that they're being left behind. There's been some fantastic work to improve people talking about other mental health conditions, but I think people are still feel that they're getting left behind around severe mental illness.
Brilliant. That's actually all the questions, I believe, for now. So yeah, just to say thank you, Jason, and you've just put your email in the chat that I've seen.
Right, yeah.
If anyone wants to get in contact with Jason,